I did med school and residency at Cornell, but it's nice to be up here at Sinai. I am here to talk to you guys about onc emergencies, which you'll often be the first person that kind of gets paged from the ED about this, or you'll be admitting someone from the ED with these various complications, et cetera. And so they're generally not terribly complicated in terms of management, but it's good to be comfortable with definitions and initial management while you wait for others to kind of give final recommendations. These slides are mainly adapted from our program director, Dr. Malone's talk to us at the beginning of this year. And so I take very little credit for the slides themselves. The things that we talked about going over are mainly the onc emergencies, less so the kind of heme emergencies, of which there are at least as many. So we're not going to be talking about things like TTP or acute leukemias or hemophilias with bleeding. But those are all also important to kind of recognize and understand. What we are going to talk about are these, and we'll kind of go through on a case-by-case basis. And then at the end, if there's time, which I suspect there will be, we'll talk about a little bit about management of initial management of brain metastases. So we'll start off with this first case, who's 54, 52. She has diagnosis of adult T-cell lymphoblastic lymphoma, who previously got treated with EPOC. It's a heavy-duty kind of lymphoma-based regimen, and now has progressive disease. So she comes in with rising white blood cells. She's lethargic. She's confused. She has poor oral intake, and she hasn't pooped for 4 days. Initial labs are notable for this. Does anyone want to shout out what is notable on these? Calcium, yes. Is it high? It is. Wonderful. Anything else that you're particularly looking for in these kind of basic labs with a story like this? Her LDH is high, right? Which, in people with heme malignancies, lymphomas especially, is common, often a not great prognostic marker. But we also look for, with the LDH, something like, tumor lysis. So elevated potassium, markedly elevated uric acid, which we don't really see here. What do you guys see about the albumin? Low. What is that going to do to the calcium? Right. So the real corrected calcium, which is the kind of body's effective calcium that you see, is higher than the 14 even. One other abnormality. Yes, white blood cells, correct. Not what I was going for, but exactly. Probably, honestly, the underlying reason for all of this, right, is the dang white blood cells. The phos is low. The creatinine, right. The kidneys are not great, right? So going back to her symptoms, right? What do you guys think is the primary cause of her symptoms over the last 4 days? The hypercalcemia, right? So hypercalcemia and hypercalcemia of malignancy is something that you guys see a fair amount, actually, I feel like, on the wards. It's graded in mild, moderate, severe, although we often kind of tend to think of it as, really anything over 12 with symptoms. Really think of it in a similar way as something that needs to be acted on, and you need to think like proactively about it. So she would have severe hypercalcemia. The symptoms, you hear bones, groans, stones, psychiatric overtones. You get lethargy, you get bone pain, you get confusion, you get polyuria. You can have EKG changes, but really people feel really weak. They feel really tired. They have bone pain, and they get constipated. And what happens then is that they lay in bed, right? These are often people who have, cancer that has progressed through multiple lines of therapy. They're somewhat weak at baseline. And when they have this, they are tired, they lay in bed, they don't drink water, and they get incredibly dehydrated. And that's one of the key things that I'll go into with the treatment of this, is that you guys should remember that like 99% of the time, these patients are going to be much more dehydrated than you actually think they are. The mechanisms of malignant hypercalcemia are a few. The one that you hear about most often is the PTHRP related malignant hypercalcemia, which can be seen in a lot of different squamous cell cancers, breast cancers, but also ATLL and other various cancers. In places that have like a diffuse bony metastases, you can have local osteolysis. And then in rare cases, but in important cases, you have calcitriol production. And so that's the 125 OH vitamin D. You can also have PTH, regular old hypercalcemia too. So the treatment is going to be IV fluids. So in medicine, I feel like we often are hesitant to give large amounts of standing fluids. It's kind of like not nearly as ingrained in us as it is, I think, in surgery or other things like that. There are several situations here where you have to like kind of actively fight against yourself and say, no, it makes sense to give this person 300 cc's an hour of normal saline. Like, the reason is they are incredibly dehydrated. Their kidneys are bone dry. Because of osmotic diuresis, with the calcium being so high, they're peeing out all their extra water. And the only way to kind of reverse the cycle is to hydrate them. You can do things like give IV Lasix as well with fluids, although we honestly don't do that very often, because at that point you're kind of thinking more about dialysis, et cetera. But in the short term, the most important thing is to start fluids and then to think about what you're going to do to get the calcium down in the medium to long range. The most short-acting and immediate acting medication that we can give is calcitonin, which is great medication. It works. You feel great. You're like, it's day like 2 of calcitonin, and their calcium went from like 15 to like 12, and you're like, wow, we're really on the way. The issue with calcitonin is that you can only give like 4 doses of it, so 2 days before you get tachyphylaxis, and so it stops working. And what happens then is that if you haven't addressed the underlying cause or given medication with a longer half-life, it just gets worse again. And so one thing I would encourage you guys is to think early on about giving a bisphosphonate. I've seen lots of times where we kind of get consulted on day like 3 or 4 once the calcitonin wears off and the calcium is back up to 16. And at that time, yeah, we have to give bisphosphonate then, but could have given it 2 or 3 days ago, and it'll kind of kick in around the time that the calcitonin wears off. Denosumab is a similar use as a bisphosphonate. A lot of this will depend on formulary and kind of personal preference. In my experience, we use bisphosphonates much more often than denosumab in the hospital. In patients who have hypercalcemia that are driven by very steroid responsive tumors, things like lymphomas, multiple myelomas, or in patients who have hypercalcemia from like granuloma formation from the 125 vitamin D, you can give glucocorticoids and it works really, really well. But generally, I would say remember to give lots of IV fluids, give calcitonin, but think about what your plan is going to be on day 3 or 4 when the calcitonin wears off. All right, case 2. It's a 43-year-old guy, no past medical history. He has bulky lymphadenopathy, he has weight loss, he has night sweats, and he has a biopsy with Burkitt's lymphoma. He has PET CT with disease everywhere. He comes in and these are his initial labs. What do you guys think is going on?
Maybe this time we'll start with people at Morningside. So you guys can give us the first 2 answers and then we'll go back to West here.
What do you guys see in terms of abnormalities on the labs?
Okay, come on, Morningside people. I'll have to zoom in into the camera to call out the names now. Don't want to get there.
The creatinine and potassium are both elevated.
Okay.
Right. Excellent.
What else? Any other thoughts here?
LDH is way high.
Anything from you guys?
Same with uric acid, it could be something like hemolysis or something.
Okay.
Right. So he has hyperkalemia with an AKI, with elevated phos, elevated uric acid, really elevated LDH, and a low calcium. What does that sound like it could be to any of you guys? Yeah. Right, exactly. So we don't have to go through all of these risk factors for tumor lysis syndrome, but the important things are that people who get tumor lysis syndromes are people with large volume cancers that respond, that either grow really, really fast or respond really quickly to therapy, to chemotherapy or steroids or what have you. And so things like bulky disease, baseline elevated LDH, pre-existing kidney disease, and dehydration, et cetera, are all risk factors for developing tumor lysis syndrome. Here, generally in the hospital, you guys will see it mostly in heme malignancies, so in high-grade lymphomas, leukemias, and in particular like germ cell tumors and small cell lung cancer, both of which are very, very fast growing, but also very sensitive to chemotherapy and steroids. You'll also can see it in HCC, in CLL, et cetera, but the real main times that you guys will see it, I think, will be in heme malignancies. The idea behind DLS is simple. It's that the cells are really rapidly dying, they're rapidly lysing, and as they lyse, you get release of potassium, phosphorus, and nucleic acids. This leads to hyperkalemia, which can be fatal, leads to hypocalcemia, which is because the phos in the cells precipitates with the calcium. This then deposits in the kidneys, you get an AKI, and along with uric acid deposition in the kidneys, you get AKI, and it can lead to basically immediate kidney failure and in severe cases, bad arrhythmias and can be fatal. This is the technical definition of lab TLS. You guys don't have to memorize it. Know though that you're looking for elevated potassium, that you're looking for elevated phos, that you're looking for low calcium and elevated uric acid. Remember, the calcium is low because it precipitates with the phos. Clinical TLS is usually what you guys will be looking for. Look particularly for the creatinine. Often you should try to spot this before the creatinine gets, quote, abnormal. So often we'll have people that comes in with creatinine of like 0.5 or something like that, and they'll get started on chemotherapy, and a day later their creatinine is 0.9 or 1, and we'll say, oh, you know, it's still normal. We don't really even pay attention to it. That's somebody that you should really, really watch for TLS, because you can get really, really rapid kidney failure. Lab monitoring, generally lysis happens in the first day, 2 days, 3 days of initiating chemotherapy. This is not something that you have to do with everybody who's getting chemotherapy for everything in the hospital, but in general, especially if it's previously untreated or really, really bulky disease, it's reasonable to be really vigilant about TLS in the first like 24 to 48 hours. And this is something that the heme consult people should be helping you out with. You get peak potassium soon after the start of chemo, and the phos a little bit later. The other important thing to remember is that the hypocalcemia, again, is because of the phos binding to the calcium. So it's really important to not try to aggressively replete the calcium, because that just makes the AKI worse. Okay, treatment. Again, talk yourself out of the whole everyone has heart failure mindset, which again, it happens in the hospital. It's that somebody comes in, they're sick, they have a little lower extremity edema, and you say, well, you know, maybe we can just do gentle, like 50 cc's an hour fluid. In people that are high risk for TLS or that have TLS, you want to give them a lot of IV fluids, and that's just, it flushes the potassium, it flushes the phosphate, it flushes the uric acid out of the kidneys, it hydrates the kidneys, and it's the best way of preventing lysis. Don't use plasma-lyte, no bicarbonate containing solutions unless they like aggressively need it. Aggressively monitor the electrolytes, and then allopurinol and respiricase are the uric acid targeting agents, which are helpful, but aren't the only reason that people with TLS die or go into kidney failure. So you can fix the uric acid, but if the phos and the calcium are still precipitating in the kidneys, then you're still kind of out of luck. So allopurinol inhibits the production of hypoxanthine and uric acid from broken down nucleic acids. So won't do anything to the uric acid that's already there, but will prevent further uric acid accumulation. Respiricase is very satisfying because it just kind of hydrolyzes all of the uric acid that you have in the serum, and you see an immediate drop in the uric acid. Allopurinol we like to give for prevention in patients that aren't high risk for TLS and have a relatively low uric acid at the beginning. The dosing is here. You can generally do like either 300 once a day or 300 twice a day. Respiricase is in patients that are high risk for TLS with already existing elevated uric acid, or in patients who you're actively worried that they are going into tumor lysis and their uric acid is rising. The dosing is 0.2 mg per kg usually over 30 minutes. The important thing about this is that it can cause hemoleucemia or methemoglobinemia in people who have G6PD deficiencies. And so it takes time to get the G6PD back. Usually now I think we get it back within a couple of days, which is great. But it's important to check, and it's important to just, if you're admitting somebody with a new heme malignancy or with a new aggressive malignancy really of any sort, like nobody is going to fault you for sending a G6PD, because it's the worst thing in the world to have somebody who's actively lysing and not be able to give them respirocase because of you don't know whether they have G6PD. Complications, we talked about it: arrhythmia, cardiac arrest because of hyper K, and renal failure, need for CVVH. Okay, case 3. So this is a guy with AML. He had 7+3, which is induction chemotherapy, which is one of the most intense regimens that we generally do. People are in the hospital for roughly 30 days and always require transfusion support, et cetera, for the middle, 10 days. He is in the middle of it. He's day 15, and he's pancytopenic. He comes in with fevers, chills, tachycardia, et cetera. His examination, he has mucositis, he has right lower lobe rails, his abdomen is non-tender, and his CBC is notable for a white count of 0.1, as well as platelets 15 and hemoglobin of 7. Okay, before I go into that, does anybody that didn't see that tell me what the definition of neutropenic fever is, or neutropenia, that you have to be worried about doing neutropenic fever precautions? Right. So this is a common question that we get. Neutropenia, in terms of neutropenic fever, and generally in terms of being really high risk for serious invasive spontaneous bacterial infections, is an ANC of under 500. Or if somebody got chemotherapy 4 days ago and their ANC is 700 today, and tomorrow you think it's going to be 200, like that still counts as, you should treat it as real deal neutropenic fever. These definitions are, they make sense. Any oral temp over 38.3 or a temperature of over 38 sustained over an hour in a neutropenic patient, although honestly, the vast majority of the time, once you get to that point, you're giving them Tylenol and treating it as a neutropenic fever regardless. The people that are highest at risk for this are people that are getting high intensity chemotherapies, which again are a lot of the myeloid or the hematologic malignancies. Patients with solid tumors can get it, but often if they have another kind of pre-existing insult to their bone marrow, if they've gotten a bunch of chemotherapy before, if they've gotten a bunch of radiation before, et cetera. Very common in patients with stem cell transplants. The risk overall in terms of kind of life-threatening infections or severe invasive infections is generally dependent on the duration and the severity of the neutropenia. And that's why the stem cell transplant patients and patients with acute leukemias are such at risk for such severe infections, is because they have neutropenia for weeks to months even. And those are the patients that get things like invasive fungal infections, and so on. The way to prevent it is to use growth factor. As an outpatient, you use on-body, which is a long-lasting version of Neupogen that you put a patch on 24 hours after you get the chemotherapy. when you're like at home, the patch like activates and gives you a sub-Q injection. It lasts for 5 to 7 days. In the hospital, we give kind of Q 24-hour growth factor. Common causes are gram positives, gram negatives, but the most common kind of febrile neutropenia cause is going to be gut translocation spontaneously. So these people don't have to have a UTI, they don't have to have an abscess, they don't have to have any of those things. They can just have gut translocation because they don't have any neutrophils. There are people for whom the physical exam is super important, right? You need to look in their mouths to make sure that they don't have any clear abscess or anything like that. If they have a ton of thrush or if they have a ton of mucositis, it puts them more at risk for bacterial translocation. Patients with sinusitis, which we see on like every head CT in, I think ever that I've ever gotten, there's like concern for acute sinusitis, but it can actually cause neutropenic fever in patients who are neutropenic. If patients have abdominal tenderness, they're at risk for both abscess formation, but also neutropenic enterocolitis, which often requires them to be NPO and bowel arrest, et cetera. And then always look at the line, because these are people who have indwelling lines, who are getting lots of labs or getting lots of medications through their lines. And so in that setting, what you don't want to do is it be 2 days in and all of a sudden realize that there's a clear, obvious infected line, and you just have to pull it out and the source is solved. You don't have to do all of these, which is nice, because that would not be ideal, but it's things to consider. Basically, every single person with febrile neutropenia should get blood cultures, ideally drawn while they're febrile ASAP, and at least a chest x-ray. If they have abnormalities on chest x-ray, and especially if they have prolonged neutropenia, I have a very low threshold for getting a chest CT, because again, these are people who get fungal pneumonias, which often look very different on chest CT. Get a viral respiratory panel, urine cultures. If they have diarrhea, C. diff, biofire, and then low threshold to pan scan. Headaches, et cetera, LP. The treatment is antibiotics, and people need urgent broad spectrum antibiotics, particularly those that cover intra-abdominal infections, particularly gram negatives. In high-risk patients, which basically everybody that's in the hospital is going to be high risk for you guys. So need to get a anti-pseudomonal antibiotic with anaerobic coverage. So cefepime is common. Zosyn is common. Zosyn will have more anaerobic coverage. And then you can consider a carbapenem. And these are also patients that often have a long history of infectious diseases. And so please look at the susceptibilities of what they've grown before if they're on their 5th admission for infections in the last 2 years, because what you don't want to do is give them cefepime when they had a ESBL E. coli in their blood from 3 months ago. In terms of duration of treatment, if you identify a source, if say there's a pneumonia, you say, okay, great. You can give a 5 to 7 day course, a kind of regular pneumonia course. And if they're still neutropenic, but afebrile, and the oncologists approve, you can transition back to prophylactic antibiotics. Most of the time, what we'll do though, is just continue antibiotics until they're no longer neutropenic. In people with unexplained neutropenic fever, they just continue antibiotics until they're no longer neutropenic. Again, in high-risk patients, empiric antifungal therapy. All these patients, very low threshold to have ID see them. And then consideration of evaluation for viral infection. Vancomycin. I'll say you will rarely get faulted for giving, if it's the middle of the night and there's a patient with neutropenic fever and they're sick and you're worried about them, you will rarely get faulted for giving them vancomycin. That said, these are the kind of NCCN indications for vancomycin in patients with neutropenic fever. So if they have any catheter-related stuff, any erythema or pain around their catheter, they get vancomycin. If they have pneumonia, vancomycin. If they have skin soft tissue, vancomycin. If they have MRSA colonization or severe mucositis, vancomycin. Same if they're sick. So case 4. This is a 53-year-old with early stage breast cancer. Got lumpectomy, radiation, adjuvant chemotherapy 5 years ago. Did great. She was then lost to follow-up. She comes in with lower back pain, difficulty walking, and she's weaker. What are you guys worried about? Right. Cord compression, cauda equina, correct. Which is very simple to say, but I find in many cases, patients are not altogether forthcoming with the fact that their legs have felt weaker for the last X weeks, etc. So a lot of times you actually get people who come in for fatigue and, you know, kind of all over general pain and, oh, my back also hurts. And then you do a neuro exam and you realize that they're actually way weaker. So in any patient with cancer who complains about lower back pain, just automatically reflects to doing at least a basic neuro exam, because this is something that can get missed and should be urgently intervened on. Her exam is notable for decreased motor strength in her bilateral lower extremities and decrease in sensation from T12 through L1, a rectal exam with normal sphincter tone. This is the MRI. You can see here, T9, you get an extension into the cord. So spinal cord compression is when a lesion compresses the spinal cord, either from a vertebral compression fracture that's malignant or from epidural extension, etc. The most common causes are going to be metastatic lesions, breast cancer, prostate cancer, HCC. Things that go to the bone often will be the case, although it can really happen with kind of any malignancy that goes to bone. You can also have intramedullary and meningeal metastases that don't have actual like spine involvement. They just have epidural involvement, and that can also cause this. It's surprisingly common. It's unfortunately a generally pretty poor prognostic sign, mainly because a lot of times it means that patients have advanced cancer and have kind of gone through a lot of available options. Again, the back pain is the primary complaint in 95% of patients, and will often precede neurologic symptoms for a long time. So in anybody with a history of cancer, even if it's remote, very low threshold to get imaging in people who have back pain, even if they think it's because they lifted something or etc. You get weakness in 60 to 85%, sensory abnormalities and about the same, but bowel or bladder dysfunction only 50%. So don't count on the bowel or bladder dysfunction as being a hallmark. People need MRIs. Unfortunately, X-rays, bone scans are not sensitive, and they will miss actually kind of scary amount of spinal cord compression. If people can't get an MRI because of indwelling devices or other reasons, you can get a CT with myelography while you kind of wait to sort out how we can get them an MRI. But really, MRI is far and away the gold standard. Please image their entire spine. Just do an MRI total spine. The amount of patients with multiple lesions, including lesions that are not quite causing severe cord compression, but will soon, is very, very high. These people often have a ton of lesions in their spine and a ton of lesions that are kind of dangerously close to causing severe issues. And those are things that we need to know about, especially the radiation oncologists or the neurosurgeons. And so would just image the entire spine, similar to anybody who has like an epidural abscess or anything like that. The treatments are pretty straightforward from our end, to be honest. Steroids, generally use dexamethasone to decrease any edema, to decrease any amount of kind of pressure that we could take off the spinal cord. But the most important thing is that neurosurgery and radiation oncology should be consulted. It should be somewhat of a reflex. When you see any concern for spinal cord compression from malignancy on a read, you should talk to radiation oncology and neurosurgery. Same thing with brain mets, to be honest. We're not going to do all that much from med-onc in the acute phase. They need neurosurgery and radiation oncology. And they also usually drive the steroid plan, to be honest. But again, nobody will fault you for giving people steroids if you have cord compression on an MRI. The surgery versus radiation question is complicated and often depends on how radiosensitive the tumor is. If there is like severe neurologic defects and kind of overall general prognosis of the patient. So I'm not going to get super into that, but know that they should both be involved regardless, is radiation therapy and neurosurgery. If people get neurosurgery, they almost always get radiation after neurosurgery to that same spot. So they should both be involved. Okay. So this is just a quick take-home points from the initial ones. So fluids for hypercalcemia, don't be afraid to give bisphosphonates relatively early, especially if people have severe hypercalcemia. If their calcium is 16 or 17 and they have metastatic solid cancer, you're not going to be able to fix that in 2 or 3 days. And so low threshold to give bisphosphonates at the beginning. Keep a close eye on tumor lysis. Again, IV fluids, use allopurinol. In people who have febrile neutropenia, give them broad spectrum antibiotics and vancomycin if needed. And then in cord compression, please call neurosurgery and radiation oncology and get a MRI. Okay. Case number 5 is a 33-year-old guy with HIV that's well controlled. He has DLBCL. He was treated with our EPOC. He now relapsed. He is feeling okay other than some neck, some arm swelling, some dysphagia when he swallows, some orthopnea, and some headache. What do you guys think might be the case?
Likely superior vena cava syndrome.
SVC syndrome, right? Which happens. And people will come and be like, wow, my face has been swollen for the last 2 weeks and I can't breathe, and you look at them and they're obviously in distress, and you're like, how did this go on for 2 weeks? But it happens. You see facial edema, you see bilateral upper extremity edema, although depending on the location, it can definitely be favor one side over the other. So what do you do? The answer is to refer the patient to ED. This is an emergency. SVC syndrome can be life-threatening if the SVC actually closes off or if you have airway compromise. And so these patients need to be seen and evaluated quickly. You can see that this guy's SVC, which is usually right around here, is obliterated and has severe compression narrowing from a mediastinal mass. So SVC syndrome, historically, syphilis, TB, you still sometimes see TB, but almost always these days, it's going to be intrathoracic malignancies or patients with extremely complex vascular history who then have stent thromboses. The most common malignancies are going to be lung cancers because of location, and lymphomas, again, because they tend to pop up in the mediastinum, but also because they're relatively fast growing and can kind of come in pretty quickly. You also do see patients with germ cell tumors or thymomas, and these things that kind of pop up in the mediastinum are the things that are most likely to cause SVC syndrome without causing havoc kind of everywhere else in the body. The pathophysiology is pretty simple. You get compression of the SVC, and you can't drain blood from your upper part of your body. People really do have bad orthopnea. They really do have bad headache and sensation of fullness. Often they don't really know how to describe it, but it really, really, really does bother people. And so it's important to really make sure that if they have orthopnea, if they have any sensation of fullness kind of in the head or face, that you don't write it off as something else. This is the exam, facial fullness, edema. The treatment, it varies actually. So depending on what cause, some tumors are more responsive to steroids, some aren't. If it's a lymphoma or something of the sort, it'll shrink fast with steroids. If it's a germ cell, steroids won't do anything. The most important thing is you need urgent imaging to assess vascular patency. You need urgent imaging to assess airway patency. You need a tissue diagnosis. You need to start them on treatment. And in the interim, this is also a vascular surgery or IR and radiation oncology like auto consult. Because if it's going to take 2 weeks before any chemo takes effect, patients often need an endovascular stent or they need radiation or something of the sort. Anticoagulation is controversial in that it's often, the occlusion is often tumor invading into the SVC or occluding from the outside and isn't like frank clot formation. But often it's honestly impossible to tell. And so if there is concern for any thrombus and the patients don't have frank contraindications to bleeding, often we'll put them on anticoagulation. But it's a little bit more complex of a question. Okay. So again, in this case, radiation oncology, low threshold for steroids, although depending on what type of cancer it is, it may not be as effective. IR, and they need inpatient coordination of care so that they can get started on therapy. Okay, last case. So it's a 66-year-old. She's got myeloma. she's got progressive disease. She has chest pain, shortness of breath, and cough. When you see her, she's sick. Her heart rate is 120. She's hypotensive, and she's got distant heart sounds, which I'm sure everyone picked up immediately on listening to her. What do you guys think she has? Tamponade, right. Which often doesn't get picked up. Often this is not something that gets picked up in the ED. It is patients come in, they're hypotensive, they're often chronically ill, and the initial diagnosis is often sepsis or hypovolemia or something of the sort. Tamponade, you have to just remember it's there. You have to just include it on your differential for everyone that you admit, not just patients with cancer, but just it's very low threshold to just put an ultrasound on their heart. You don't have to be good at POCUS. I'm not, but it's easy to see giant pericardial effusions, and it changes management immediately. So this really is something that will not often get picked up until day 2 or 3 of the hospitalization. So you can have malignant pericardial effusions, which can be from tumor invasion, from METs, from inflammation from radiation, from infection, from autoimmune processes. Honestly, in the acute phase, it doesn't really matter. If they have tamponade or if they have a large effusion with signs of impending tamponade on echo, they only need one thing, and it's not oncology, it's a pericardial drain or a pericardial window. They need cardiology and maybe cardiothoracic surgery input. So the symptoms are, again, dyspnea, cough, chest pain. You get pulsus paradoxus, which is great to check. You get distant heart sounds, and then you can get really rapidly progressive shock and organ failure. The EKG, you get low voltage stuff. This will often actually be picked up on chest CTs for people that are concerned about PE. They'll do a chest CT, and instead of having a PE, there will be a moderate to large size pericardial effusion. That's something to look for. And then the diagnosis of why they have an effusion is almost always done via biopsy or fluid cytology, at which point they are in the hands of cardiology and cardiothoracic surgery. The treatment, if it's small to moderate, they're not symptomatic, there's no signs of echo. You monitor, you think about why it could be there. You sometimes will take a sample to see if it's malignant versus inflammatory, et cetera. But the most important thing is that if they're symptomatic or it's rapidly enlarging, they need pericardiocentesis or pericardial drain, and we'll figure out how to treat the underlying cause later. Okay. I think that's it. Brief spiel on brain mets, which is get an MRI, call radiation oncology, and call neurosurgery. Let us know. But the management is similar to cord compression in that often local therapies and steroids are what's acutely needed for them. It takes far too much time for a chemotherapy to kind of treat symptomatic brain mets. So, all right.
Oh, thank you so much. I guess just to wrap up the session, maybe I'll quickly go around the room and we'll just review one case at a time, and you guys can shout out anything you like are going back with that, or like anything new you learned. It could be anything as simple as, okay, don't ignore hypertension for your diagnosis of tamponade. Okay, so first for hypercalcemia. Okay, maybe we'll start with this table. What was something that stood out to you or that you're walking up with?
Don't be afraid to give a lot of fluid.
Awesome, perfect.
Oh, we want for every single.
Okay, so and the TLS, the one is not table learned from TLS.
Baseline.
Get an EKG.
Get an EKG.
And what you're looking for?
So we're looking for QRS whitening, signs of hyperkalemia. Okay.
I'm going to go with the malignant spinal cord compression. So imaging the total spine, not just where it hurts or wherever there are symptoms related to, is important.
Awesome.
You can repeat.
Sure. One thing that I picked up, you were saying get the radiation oncology team and the neurosurgery team on board. That's really the people you should be calling all together.
How about that morning site? Morning site. You can repeat if something was mentioned before. Oh, you're muted. Okay, so we'll end up here. Thank you so much. Let's take, see, 5-minute break. And
Thanks, guys.
Oh, I can update them if you. Okay. Can I get into my email? This is the one I have in case you want.
Okay. I can just, if I can get into my email, I can just do the most updated
I
one.
think Ram forgot to sign
Okay.
out. Yeah, sign him out. There you go.
Thank you. Oh, how do I?
Oh, I like slides. You actually. I don't have slides. Okay. We will post.
I will, but if I'm
Let's see.
All right.
Sorry, I'll quickly show them the attendance QR code. Yeah, sure. And then we'll need to share it on Zoom as well. Are you logged into?
I don't think I'm logged into my.
Okay, no worries. I just didn't want to accidentally sign you out.
Yep.
No, you're- And then I can go back to yours. Okay, guys, we're gonna get started in a minute. So why don't you scan the QR code really quick? Okay, everyone got the QR code?
Yeah.
And you had it here. Mhm. I think I never stopped. So. Okay, there you go.
Okay.
Mhm.
We good?
Yeah.
Okay. So this is not just thyroid and adrenal emergencies. It's all kind of high yield thyroid and adrenal things because it's hard to talk about just emergencies for a full hour. Everything is case-based, so just a bunch of questions. I'll just probably answer them myself for you because I think it will be hard to get through everything if we pause. But if you have any questions at any time, just stop me and ask. So the first question, so it's going to be a mix of different thyroid and adrenal cases. So there's a 33-year-old woman who has a past medical history of Graves' disease. She comes to you at 6 weeks pregnancy of gestation to confirm her pregnancy. She was diagnosed with Graves a year ago, and she's currently on methimazole 20. She feels good. She has no palpitations, no tremor or weight loss. Her temperature is normal. Her blood pressure is normal. Her heart rate is normal. Her respiratory rate is normal, and her physical exam just shows a diffusely enlarged thyroid that's not tender and no nodules. Her labs are basically normal. Her TSH is 0.5, her free T4 is 1.9, her total T4 is 15, and her total T3 is 202. These both are just a little bit above the upper limit of normal. I don't have normal ranges here. So what are we going to do now? What's the next appropriate step? Are we going to continue the methimazole? Are we going to increase the methimazole? Are we going to stop the methimazole and initiate PTU? Are we going to stop the methimazole and check her thyroid function test every 4 weeks? So the answer is we're going to stop the methimazole and initiate PTU. For hyperthyroidism, we very rarely use PTU except in the cases of thyroid storm and pregnancy. The reason is that PTU, so the antithyroidal medications, have the ability to cause genetic birth defects. There's a risk with both methimazole and PTU. The risk is higher with methimazole. So you have a 2 to 4% risk of birth defects. I'm sorry, the risk is not higher. The defects are more severe with methimazole. So if babies are exposed between 6 and 10 weeks of gestation, you have a risk of aplasia cutis, choanal or esophageal atresia, abdominal wall defects like omphalocele, and eye urinary defects and VSDs, whereas babies exposed to PTU typically have like face and neck cysts. So PTU is the one time we very commonly use, the first trimester of pregnancy is the one rare time we use PTU. We switch back to methimazole as soon as the patient enters a second trimester because the risk of hepatotoxicity is higher with PTU in general. So that's why we don't use it more commonly. The potency of methimazole to PTU is about 1 to 20. So if you have a patient on 20 milligrams of methimazole, you switch them to about 150 BID of PTU. And this is probably a question that would come up commonly on the board exam. When you are pregnant, your TBG goes up. TBG is a binding globulin that's bound to thyroid hormone. Estrogen stimulates it to go up, just like it would stimulate cortisol binding globulin or any other binding globulin to go up. So a total T3 and a total T4 that are slightly elevated in pregnancy is normal. You titrate hyperthyroid patients in pregnancy to keep the total T3 and total T4 less than 1.5 times the upper limit of normal. And the free T4 is just not an accurate test in pregnancy. We sometimes check a free T4 by equilibrium dialysis, but a free T4 by itself is not an accurate test. How do you treat hyperthyroidism in pregnancy? This is just a chart that basically is showing everything that I just told you. You're switching to PTU before you're trying to conceive, switching back to methimazole in the second trimester. The way Graves works is typically the course of the disease. It sometimes gets a little bit better as the pregnancy goes on. You can run pregnant patients a little bit hyperthyroid. It's more dangerous to run them hypothyroid. So we can sometimes run them a little hyperthyroid. If we can keep them off methimazole at all, you try. But again, keeping the total T3 and total T4 less than 1.5 times the upper limit of normal is best. Okay. This is an 80-year-old man. He's in the ICU. This is an adrenal case. He has gram-negative sepsis due to pyelonephritis. He has a past medical history of AFib. He takes Coumadin and metoprolol. He has no history of head trauma or surgeries. In the ICU, he's on antibiotics, suppressors, metoprolol, and heparin. He's awake, lethargic. He's febrile, mildly febrile, and he's tachycardic. He has mild crackles at the bases, and the rest of the exam is relatively unremarkable. He is non-palpable thyroid and no masses or nodules. So his random cortisol is 17. His thyroid antibodies are negative. His TSH is 0.3, a little bit below the lower limit of normal. His total T4 is 78. His free T4 is 0.9 and his total T3 is 68. And this is also a question you probably see on your boards. What's the next step in treating this patient's abnormal thyroid function tests? You don't treat, you recheck in 5 days. You don't treat, you recheck in 8 weeks. You can start levothyroxine because he has central hypothyroidism. You can start methimazole because he's hyperthyroid, or you can start PTU because he's hyperthyroid. And the answer is you don't treat and you recheck the thyroid function test in 8 weeks. So this is a case of euthyroid 6 syndrome or non-thyroidal illness. So when patients are sick, when patients are on steroids, cortisol levels are high, certain drugs like amio and propranolol, they reduce the 5-monoiodination. So when nutritional intake is low is another one. And this enzyme here is inhibited. And basically you have a shift in the pathway. So this is the one instance, I mean, we don't check reverse T3 ever, but if you did in a patient with euthyroid 6 syndrome, it would be high. Typical labs you see are a decrease free in total T3. You have an increased reverse T3. And you have a decrease in T4. Typically, a very low T4 typically portends a poor prognosis, and the free T4 is usually normal, but then can be lower as the patient gets sicker. The TSH is usually normal initially, and then it's suppressed. And then in the recovery phase, it can be elevated, but it's usually not greater than 20. And then TFTs, it usually takes the hypothalamic axis to about 8 weeks to recover. So the TFTs usually normalize about 8 weeks after. So again, we're going back to this guy's labs. He's got, oops, sorry, going the wrong way. He's got a mildly suppressed TSH. His free T4 is normal. His total T4 is a little bit low, and his total T3 is a little bit low. So, you know, when you're looking at hyperthyroidism, again, you're looking for the free T4 total T3 to be high. That's not what's going on here. So this is a very classic pattern of someone who has non-thyroidal illness. And again, just doing nothing. So this is just basic thyroid function test interpretation. When the TSH is low, the free T4, I don't know why this is free T3, because really when we're checking hyperthyroid patients, if you're checking a free T4 and a total T3, the only time you're checking a total T3 and a total T4, not a free T4, is in the case of pregnancy. You typically have a suppressed TSH and a high free T4 and total T3 when patients are hyperthyroid. Subclinical hyperthyroidism, you have a low TSH and a normal free T4. And in cases of thyroiditis, the ratio of the free T4 elevation is usually higher than the ratio of the total. The free T4 elevation is higher than the total T3, and in Graves, you typically see a T3 toxicosis. But in the case where the free T4, the total T3 and total T4 on the lower side and the TSH is low, patients sick in the hospital, that you're usually looking at a non-thyroidal illness. Okay, next one. This is a patient who, 20 young girl, she comes in, she has a left-sided thyroid nodule, is detected by her PCP. The PCP ordered TFTs and thyroid ultrasound and referred her to you. She has no compressive symptoms or symptoms of hypo or hyperthyroidism. Her gland is symmetric, with the left lobe being larger than the right. You palpate a nodule in the left lobe, but the rest of the physical exam is normal. Her thyroid function tests are normal. And this is what you see on the left. So this is thyroid ultrasound. This is what you see on the left side. And this is what you see on the right side. Okay. I guess we can maybe make it a little more interactive. Do you guys know, what would you suspect you do here? You do a biopsy of the left-sided nodule, a biopsy of the right-sided nodule, biopsy of both, follow up in 6 months, or do a thyroid uptake and scan? What's that?
Would you
Go
do
ahead.
the thyroid scan before considering a fine needle aspiration?
Okay. So the TSH is normal. So that's important to consider. So TSH is normal. So the patient, what's that?
Is there concern for like a cold nodule, which is more concerning for malignancy? So you want a biopsy?
Yeah.
And I think one looks like a cyst, so maybe you'd hold off. I'm not sure, but maybe that one's kind of scary.
So you do a thyroid uptake and scan in the case of determining the etiology of typically hyperthyroidism. So the patient has a normal TSH. There's really no indication for a thyroid uptake and scan here. Here we're looking at basically a cyst. Okay. So when you're looking at a thyroid nodules, so the answer is B, we're biopsying the right-sided nodule and not the left. Okay. So I'm going to show you pictures in a second. So this is just basically a chart of different sorts of thyroid nodules. Benign nodules are typically cystic. They're typically, this is a cyst right here on the bottom. And these are these are benign. So you see this dark center. This is the normal thyroid gland. It's kind of like this whitish echo texture. People that have thyroid disease, this looks a little more like moth-eaten appearance. It's a little more heterogeneous. When you have a nodule that looks like this is a spongiform looking nodule. These are low suspicion nodules. These nodules here that are partially cystic, again, low suspicion. As we're going up here, the most concerning features we see in thyroid nodules are nodules that are hypoechoic. They're irregular. Hypoechoic means that they're darker in comparison to the thyroid gland. So the echo texture of the nodule is darker. So in this case, for example, we see this is isoechoic. Oh, this is a hypoechoic nodule because this is a little bit brighter. But in this case here, you see the texture is very similar to the thyroid gland. That's isoechoic. This is a little bit of a lower suspicion. And you can have hyperechoic nodules here too. These are also lower suspicion. But when we have hypoechoic nodules, so we're looking at the thyroid, we're looking at the nodule, it's darker. The nodules that are irregular. And then there's also something called microcalcifications. You can see these microcalcifications here, 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 here. Those are concerning features. And thyroid nodules also that are taller rather than wide. So in this case, this is tall rather than wide. If it were wider than tall, it would be less concerning. These are concerning features. So if someone has a hypoechoic nodule that's irregular, has microcalcifications, is a high suspicion nodule and needs to be biopsied when the nodule is greater than 1 centimeter. When we get to the lower suspicion pattern, so these patterns here, these spongiform isoechoic nodules, we biopsy them when they're greater than 1.5 centimeters. And when we get to the very low suspicion, like the spongiform nodules we talked about, we can wait until they're 2 centimeters. So going back here, this patient has this, kind of hypoechoic. See these irregular margins here. And this is something that might be on your board. So I might put a picture here and describe these sorts of things. That this is irregular and it's hypoechoic. It has these microcalcifications. You have to biopsy that. The cyst you don't touch. And again, like this is a nodule that's irregular and it has microcalcifications, it's hypoechoic. This risk of malignancy is greater than 70, 90%. Most of the time you can't palpate these. You actually, on this exam, you palpated the cyst. A lot of the times you don't palpate these. A lot of these things are found incidentally when patients go for scans or stuff like that. They're not palpable a lot of the time. Okay, so this is, I don't know if you guys, they get this chart. Do they get these slides? You can give them the slides because this is very good. This is from the ATA guidelines. And so is this. Again, this is just another example. This is a spongiform nodule here right down here. This is kind of an isoechoic nodule. It's round, it's regular. It doesn't really seem very concerning to me. This is a cyst. And this looks like a thyroid cancer to me. So it's taller rather than wide. It has some microcalcifications and it's hypoechoic. The margins also are a little bit irregular. Okay, this is a 55-year-old female. She has a history of breast cancer. She's on letrozole. She's incidentally found to have an adrenal mass on her CAT scan. Her blood pressure is normal. Her weight and height are normal. She has a normal BMI. The rest of her physical exam is normal. She has an 8 a.m. cortisol after a 1 milligram overnight dexamethasone suppression test. That's 1.1. Her metanephrines and norepinephrines are normal. Her aldosterone level is normal and her renin is normal. This is what we see. This is an adrenal nodule here. It's a 2.7 adrenal nodule. It has a Hounsfield it has a density of less than 10 Hounsfield units and a greater than 50% washout 10 minutes after contrast. So the question is, what are we going to do next? We're not going to do anything. We're going to biopsy it. We're going to do an adrenalectomy. We're going to do a PET scan, or we're going to do an adrenal MRI. Anyone?
It's less than 4 centimeters.
Mhm.
So, and can we just go back one time? I just want to check one thing.
So it's 2.7 centimeters, has a low density and a high washout.
I forgot the other criteria, but it's relatively small. So I would probably just do nothing for it.
Yep, do nothing is the right answer. Okay, so this is a chart of the different characteristics of adrenal adenomas that you see. Up top, it says if you have a non-contrast CT that shows a small, less than 4 centimeter adrenal mass that's less than 10 Hounsfield units, you don't need to do any contrast imaging. You can leave it alone. Basically, when you're looking at a benign adenoma, which are detected a lot, you have smooth contours, it's homogeneous, they're usually unilateral and less than 4 centimeters, and they're not dense, okay? So the adrenal gland is made up of lipid. So lipid is fat and it's not dense. So when you have pathology, the lesions get more dense. Non-pathologic lesions are more lipid rich. And there's rapid washout, so greater with contrast, so greater than 50% washout 10 minutes after contrast. That's benign. When you have Mets, they're usually irregular. They can be variable in size. They're usually more dense, greater than 20 Hounsfield units. There's delayed washout. Pheochromocytomas are typically by the time they're causing symptoms big. So they're typically greater than 4 to 5 centimeters. You can incidentally find pheos. People aren't always largely symptomatic. However, by the time people are clinically symptomatic, the tumors are usually pretty large. There's a delayed washout, and they have higher density. And then hold on, I can't see this on the adrenal cortical carcinoma, same thing. They're typically large and they're typically dense. So if you have a small lesion that has a rapid washout, it's smooth, you can just leave people alone. Sometimes you can just reimage them in a year if you're worried. Okay. And these are things to also know for your boards. This chart is, I think it's also in Mix-Up. It's not this exact one, but something similar is. Okay, 35-year-old, he has a 40-pound weight gain over the last 3.5 years, despite exercising and eating healthy. He has no skin changes or muscle weakness. He has a past medical history of hypertension, epilepsy, impaired glucose tolerance. He's on lamotrigine, carbamazepine, lisinopril, amlodipine, and a statin. He's centrally obese. He has pale striae over the abdominal wall, but no other skin changes. His BMI is 38.5. He has no proximal myopathy, and his blood pressure is a little bit high. These are his labs. So he's got, this is the most notable lab. His cortisol level after a 1 milligram overnight dexamethasone suppression test is 14. So the question is, what's the next most appropriate step?
To give you guys a hint, maybe we can go back to question and you can see what stands out on his physical exam. And then the abnormal test that Dr. Brown pointed out, like the dexamethasone suppression test, you guys can shout out or like share when do you get it and when do you get concerned. So let's start with the physical exam. Anything abnormal?
So patient is centrally obese. Also, he has a past medical history of hypertension. There are pale striae over the abdominal wall, but no other skin changes, and has proximal myopathy. So all of these are
no proximal myopathy.
Oh, sorry, no proximal myopathy. Okay, then let's cross this out. But so the other findings are just by themselves are concerning for like Cushing syndrome or disease, depending on where the tumor is, if it's in the pituitary or it's in the adrenal gland. And in this case, I think TSH was normal, like other pituitary hormones, hormones were normal. So I am concerned that like this is in the adrenal gland. So I would get adrenal CT.
Okay.
But not sure.
So the answer is actually a 24-hour urinary free cortisol. So basically what this question is getting at, this is a screening for Cushing's again. And so Cushing's, when you have pituitary tumor and ACTH producing adenoma in the pituitary gland, it's called Cushing's disease. When you have a tumor in the adrenal gland, it's called Cushing's syndrome. There are a lot of people in this country that are hypertensive, that are overweight, that have central obesity, but that also, you know, so that's why there's a lot of screening for this done. In this physical exam, he's centrally obese. Yes, you see that with Cushing's disease. Cushing's patients typically have purple striae. They're large, thick purple striae. They're not pale. Most people that you see with kind of stretch marks, they're pale striae. That's the difference. They typically have a proximal myopathy, not all of the time. But the biggest skin change is the pale, the striae are typically purple. The abnormal part of this test is the cortisol is high. Now you should always be checking a dexamethasone level when you do an overnight 1 milligram dexamethasone suppression test. The way you do it is you give 1 milligram of dexamethasone between 11 and 12 p.m. The night before, you check a cortisol level between 8 and 10 a.m. You always need a dexamethasone level to make sure the dexamethasone is being metabolized appropriately, because this person might not have even taken their dexamethasone. Caveats to this test: this is a total cortisol level. The 1 milligram dexamethasone suppression test measures the total cortisol level, which total cortisol is bound to CBG. So patients who are on oral contraceptive pills, people who are pregnant, this test is not accurate. You need to do a 24-hour urine-free cortisol or a late-night salivary cortisol test, because those are free cortisol levels. What this is getting at is that there are a couple of first-line tests in the initial screening for Cushing's syndrome. The first is a dexamethasone suppression test, but you also have late-night cortisol, salivary cortisols, and 24-hour urinary-free cortisols. Cushing's is one of the most difficult diagnoses to make in clinical medicine. It's a very difficult diagnosis to make. You always have to check another test. So you had an abnormal dexamethasone suppression test. The suspicion for Cushing's in this case is actually low. He doesn't have myopathy. He doesn't have thin bruised skin. He doesn't really have striae. He doesn't really have any other symptoms. So we're just going to check something else. And that's a 24-hour urinary free cortisol. Again, when you're checking a 24-hour urinary free cortisol, you're also checking a 24-hour urine creatinine with that to make sure that that's accurate too, because the urine collection can be inaccurate. So again, if you have one abnormal result from one test, you have to do a second. So normally there's been arguments about this, but normally typically the cortisol should suppress to less than 1.8 when the dexamethasone is administered between 11 and 12. And again, you have to check a dex level when you check the cortisol. Okay. This is a 57-year-old. She has Graves. She's taking methimazole 30 and atenolol 50. She stopped her methimazole a week ago, and she's coming in with 3 days of nausea, vomiting, and palpitations. On exam, she's febrile. She's tachycardic. She has proptosis, conjunctivitis, and she has a goiter with a bruit, and she has rails at her bilateral bases, and she's tremulous. Why can't I click? Her free T4 is greater than 7. Her free T3 is 12.1. Her TSH is suppressed. She has a high bilirubin. She has an EKG with sinus tachycardia and a chest X-ray with interstitial edema. Oh, where's the? Oh, I don't have a question here. I don't know why. So this is something what we're looking at here is a case of thyroid storms. This is a patient with Graves' disease who stopped taking her meds. She's coming in with a couple of different things. She's tachycardic. She's hemodynamically unstable. She's febrile. She's now has rails at her bilateral bases. She clearly has evidence of Graves' ophthalmopathy with a proptosis and conjunctivitis. Her gland is big and it has a bruit. You listen for bruits, patients who have thyromegaly, by putting your stethoscope over the thyroid gland, ask them to hold their breath. And you typically hear a shh, shh, shh. We have to make sure the patient's not breathing to make sure it's not their breath, but that's just sign of a hypervascular thyroid gland. Her free T4 is high, her TSH is suppressed. Now her bilirubin's a little bit up. So thyroid storm is something that is rare, but you can't miss it because it has a high mortality. You typically see patients who are in thyroid storm typically are febrile. They have hyperprexia. They have large insensible fluid losses. They have nervous system problems. They're confused. They can have seizures, can be in a coma. They're tachycardic. They can have atrial dysrhythmias. They can go into heart failure. They have hepatic dysfunction or jaundice, psychosis. There's typically a precipitant, and it's very serious. So it has to be detected. That said, most people in the emergency department who are hyperthyroid, have thyroid toxicosis, are not in thyroid storm. So not to be missed, but not to be diagnosed in everyone who's hyperthyroid. This is the Birch-Wartowski scale. Is probably the most common scale used in evaluating someone for severe thyroid toxicosis, and a score greater than 45 is most consistent. So you're looking at fever, heart rate, whether or not they have evidence of congestive heart failure. Do they have CNS effects? Do they have hepatic dysfunction? Do they have AFib? And do they have a precipitant history? So it's something trigger this. The way you treat it is you direct your treatment at every therapeutically accessible target. So you want to inhibit thyroid hormone synthesis and release. You want to prevent the peripheral effects of thyroid hormone. You want to get thyroid hormone out. and you want to systemically support the patient and treat the precipitant if there's an infection or something like that. So how do you inhibit thyroid hormone synthesis or release? PTU, this is another case in which you use PTU. Studies have shown that you just drop your T3 levels a little bit quicker than when you use methimazole. You can saturate the thyroid gland with SSKI, which is iodine. The thyroid uses iodine to make thyroid hormone. There's something called the Wolff-Chaikoff effect, where if you super saturate the thyroid gland with iodine, it stops making thyroid hormone. Patients with a normal thyroid gland have the ability to escape the Wolff-Chaikoff effect. After time, they'll suppress thyroid hormone synthesis. After time, they'll escape it and they just will start making it again. Patients with underlying autoimmune thyroid disease don't always have that ability, so they can remain hypothyroid. So you give them SSKI, and then you, in addition to the PTU, you inhibit the peripheral conversion of T4 to T3. Again, T3 is the active form of thyroid hormone with PTU, propranolol, steroids, and then you block the end organ effects of the thyroid hormone with steroids and beta blockers. And then you can physically remove thyroid hormone if the patient's really sick with plasma exchange or cholestyramine, which you give 4 grams 4 times daily, and it basically gets you to fecally excrete it. So in patient that you really suspect has thyroid storm, you're throwing the kitchen sink at them, you're giving them all of these things. Esmolol, you can give esmolol or propranolol. And you can give hydrocortisone or you can give Dex. This is just kind of the summary of the medications used. What it precipitates it, radioactive iodine therapy, taking away the antithyroidals, thyroid surgery, non-thyroid surgery, palpating a patient with Graves' disease gland, contrast, infection, childbirth, all of these sorts of things can be precipitants for this. Okay. On the opposite end of the spectrum, we have a 72-year-old who's admitted to the ED. She has pneumonia, bradycardia. She has a first-degree AV block. She has somnolence. She has Graves' disease treated with RAI. So she's taking Synthroid. She's taking a statin. She's taking an ACE inhibitor. She's hypotensive. She's cold, dry skin. She's somnolent and disoriented. Her heart rate is 48. Her breathing is shallow. She has crackles in bilateral lobes of her lungs, and she has some face edema. She's got leukocytosis. She's a little hypoglycemic, hyponatremic. And her TSH is 35 with a free T4 of 0.4. So the question here is, which of the following is false regarding this patient? The pneumonia is what likely precipitated it. The most likely etiology is untreated hypothyroidism or myxedema coma. Myxedema coma is the cause of the patient's presentation is unlikely, given that the TSH is only 35 and TSH levels are usually about 100 with myxedema coma. Or this patient should be managed with intubation, broad spectrum antibiotics, hydrocortisone, and LT4. So what's false? Not true. So all of them are true except for one. Yeah, that's correct. So the TSH level does not correlate with the severity of clinical presentation. So there's a lot of different things that can reduce TSH levels, just like we talked about before. Stress, steroids, meds like dobutamine, dopamine. Myxedema coma is a very extreme and life-threatening expression of severe hypothyroidism. Again, most of the time, this is not what hypothyroid patients in the emergency department have, but it's always something to consider because it should not be missed. 80% of the cases occur in women over 60. What can do it? Withdrawal of LT4, which is levothyroxine, infection, strokes, trauma, a cold temperature, GI bleeding. Patients are hypothermic. They can have CNS, respiratory, cardiovascular manifestations, GI manifestations, hematologic manifestations. They can have coagulopathies, DIC. From a GI perspective, they can have a lot of edema. They can have impaired peristalsis, GI bleeding due to the coagulopathy. They can be bradycardic, have prolonged QT, reduced cardiac output, tamponade, decreased hypoxic respiratory drive. They can be in a coma, disoriented, depressed. And so, you know, the case that I'm an endocrinologist, and I've actually only seen this truly one time, and it was when I was moonlighting as a hospitalist. I came onto the service on a Monday, and like number 15 on the problem list that people were writing over and over and over was that this patient with metastatic breast cancer was getting her home Levoxyl that she was bringing in because she's allergic to levothyroxine, so they weren't giving it to her in the hospital. So first of all, nobody's really allergic to levothyroxine. I went and checked a TSH because I was like, that sounds like a fishy story. Is she really bringing it in? And meanwhile, when I came on Monday, they were calling code strokes. Neurology was involved because the patient was disoriented and wouldn't wake up. Her TSH was 64. Her free T4 was 0 because no one was giving her levothyroxine, and she had a total thyroidectomy. She had a total thyroidectomy, so she didn't have a thyroid. So the second we gave her thyroid hormone, she woke up. So again, like not something that you see often, but always something to consider, especially like when people are in the hospital and hypothyroidism is like number 22 on the problem list and people are copying and pasting notes. It's just always something, you know, especially people with neurologic issues, something to consider. You have increased serum EDH and impaired water diuresis. That's why you have hyponatremia. You can have decreased glomerular filtration rate and renal plasma flow. Atony of the bladder, retention of large residual urine volumes. You could have rhabdomyolysis. On physical exam, hypothermic, they can have macroglossia, hoarseness. And again, all these things don't have to be present. They can be bradycardic, delayed reflexes. They can be hypoventilating. This is another scale that kind of gives you some sort of guide, looks at temperature, cardiovascular dysfunction, central nervous system effects, metabolic disturbances. So the lab results are really important to look at. GI findings, whether or not there was a precipitating event. Again, like in the case of my lady, somebody just wasn't giving her thyroid hormone and she didn't have a thyroid gland, so needs thyroid hormone. So again, we have to support these patients. They usually need to be intubated. We have to restore their body temperature, correct their hypotension, correct the hyponatremia. So all supportive care. You typically give a single IV dose of levothyroxine of 200 to 400 micrograms, followed 24 hours later by 100 micrograms, and then followed by a maintenance dose. So a maintenance dose of levothyroxine. So if you have a patient who comes in who's just hypothyroid, the way you calculate the levothyroxine dose is you do 1.6 times their kilogram. So it's 1.6 mics per kilogram. And that's their weight-based dose. If someone's overtly hyperthyroid, you typically start a weight-based dose of levothyroxine, and then you recheck again in 6 weeks, 4 to 6 weeks. So in this case, and when you're converting from IV, from PO to IV, you'd reduce the dose by about 75 to 80%. You don't have to reduce by 50%. So 24 hours later, you do a maintenance dose of 75%. You also typically give T3 until they start to wake up. So you give a bolus of T3 and then you continue at 2.5 to 10 mics every 6 to 12 hours until they're conscious and able to take it. Sometimes the rate of conversion of T4 to T3 is reduced in systemic illness. And again, T3 is the active form of thyroid hormone, T4 is not. That's why if you give patients Synthroid, even if you give them too high of a dose, they're usually not going to have symptoms. If you give patients actual T3, they will. And again, if this is something you're suspecting, it's like adrenal insufficiency. You're not waiting for tests, you just treat. So this is serious and should be treated right away if there's any suspicion of it. Okay, this is definitely not an emergency, but this is something that probably will be on your boards, and if they're gonna, which they will ask endocrine questions. You have a 30-year-old female. She's trying to get pregnant. She's now 1 week post missing her period. She's on levothyroxine 125 micrograms. A month before, her TSH was 1.2, so she's well controlled. Her physical exam is normal. She has no thyromegaly. What are we gonna do now? She has a normal TSH and now she's pregnant. Yep, increased by 30%. So early on in pregnancy, the need for thyroid hormone increases dramatically. Patients that are trying to conceive a baby that have positive TPO antibodies, their TSH should really be less than titrated to be less than 2.5, not just in the normal limit, because patients who have TPO antibodies and have a normal TSH have some sort of underlying autoimmunity. Most usually the TPO antibodies form in reaction to inflammation in the thyroid gland, and basically they lack the ability to really mount the response. You really have to keep those patients tightly controlled. But the bottom line is early on in pregnancy, the demand for thyroid hormone really grows up. And so you have to increase your levothyroxine by 30%. When I was in fellowship, the guy who focused on this would always say, you call me, then you call your mom, then you call your husband when you find out you're pregnant. Because, I'm the most important one. You really have to increase the dose right away. So this is the ATA guidelines. You can accomplish this different ways. You can just have patients take an extra couple doses a week. That's not going to be specifically on your boards, but people that want to get pregnant really should have a TSH less than 2.5, especially if there's TPO antibodies. Without TPO antibodies, that's a little more debatable, but I always keep my patients less than 2.5 if they want to get pregnant. And then you increase the dose the second you find out. Okay. This is a 30-year-old female. She has 3 months of fatigue, nausea, poor appetite, salt craving. She lost 10 pounds. Oh, she went from a boy to a girl. Okay, so now she has a 10-year history of hypothyroidism treated with levothyroxine. So on exam, she's a female, she's tan, she has hyperpigmentation of the gum line. Otherwise, exams unremarkable. She's a little hypotensive and orthostatic. Her heart rate is high. There's no muscle weakness. She is hyponatremic with a little bit of a high potassium. Her TSH is 6. Her random cortisol at 1 p.m. is 2.5. Her ACTH is 234, and her DHEA sulfate is 0.2. What are we doing? What is going on here? What's the next appropriate management? Anyone? Give her steroids. Yeah.
Can we go back to the question?
Yeah, sure.
Are you concerned about this patient?
What's that?
Like, no, I'm asking the residents.
Sorry.
So based on all the information we have available, are you concerned about this patient? Should we prioritize maybe interventions and try to do them at the same time as we do some testing? And then clinically, what is your suspicion in this patient? Yeah. Adrenal insufficiency. Yeah, so we see the hypotension, we see the hyponatremia, and glucose, is it around there?
Yeah,
But,
glucose. I don't have a glucose.
okay, but overall clinical, like adrenal insufficiency, we're suspecting.
And so
a
on physical
patient,
exam, you're looking at a tan, they have hyperpigmentation of the gum line and tan skin, which is telling you that this is maybe primary.
most likely Addison's disease, primary adrenal insufficiency.
Yep.
So, but the patient is in shock, right?
Mhm.
So what are you going to do next?
Mhm.
Steroids, right?
Yep, exactly. Okay, so the patient has classic symptoms of primary adrenal insufficiency. The most classic symptom of primary adrenal insufficiency is anorexia, loss of appetite, but they can be fatigue, nauseous, they can lose weight, they can have like muscular symptoms. Not always though, they don't always have all of these things. So they can be lab-wise, typically they're hyponatremic, hyperkalemic, they have a low cortisol with a high ACTH because the pituitary gland is intact. This is primary adrenal insufficiency. The disease is in the adrenal glands. They have low adrenal androgens. The AM cortisol is a preferred test. You typically check the AM cortisol between 8 and 10 a.m., but this PM cortisol is inappropriately low for this level of hypotension. So she shouldn't have, if she's hypotensive, she should not have a cortisol of 2.5. She also already has one autoimmune condition, which is very important to consider. People with one autoimmune condition can often have another autoimmune condition. So she's hypothyroid. So it's important to like have a higher suspicion, especially on a board question when they're telling you stuff like that. They're not telling you stuff like that for no reason. You have to, before you ever adjust a thyroid dose, actually in mixed edema coma, I didn't even have this on my slide, which is a mistake, but you should always be giving a dose of hydrocortisone before you give levothyroxine. And the reason is people that are hypothyroid, severely hypothyroid, I can't believe I don't have that on there, but you should always give hydrocortisone first, because if there's any concomitant adrenal insufficiency and you give levothyroxine, somebody who has a slow metabolism, and then you give them levothyroxine, you're going to speed it up. You're also going to increase the metabolism of steroid hormone. And so if you have any underlying adrenal insufficiency, you're going to go into you're going to have an adrenal crisis. So when you're treating mixed edema coma, you give a dose of hydrocortisone, 100 milligrams usually first. And so that's what this says here. So you must always address adrenal insufficiency prior to adjusting any levothyroxine dose, because I think the TSH was abnormal here. So the TSH is abnormal, but we're not worried about that right now. And again, the increased ACTH is a physiologic response to decreased cortisol and shows that the pituitary function is not impaired, which basically tells us that this is primary adrenal insufficiency and not secondary, in which case you see an inappropriately normal or a low ACTH. A lot of the times it's just inappropriately normal. If you have a low cortisol, your ACTH should be high. Okay, this is a 25-year-old who's coming in for a 2-week history of neck discomfort, palpitations, anxiety. She had a sore throat 4 weeks ago that then resolved. She has no history of thyroid or other endocrine disorders. She takes a birth control pill. She's anxious on exam. She has a low-grade fever. Otherwise, she's a little tachycardic. She has multiple fevers here. It was a mistake. She's tachycardic, and her thyroid gland is a little bit enlarged and tender, but there's no nodules, no brewery, no cervical lymphadenopathy. She has no proptosis, and she has tremor. She has, I don't have the ESR here. The ESR is a little bit high. The TSH is low. The free T4 is high, and the total T3 is high. On thyroid, she has an enlarged gland that's heterogeneous and without lymphadenopathy. So what are we going to do here?
Can we go back to?
Yeah. So there's nothing to FNA. There's no nodules, so that's out. Serum thyroglobulin, methimazole. So definitely she's hyperthyroid. The question is, when someone is hyperthyroid, the question is why. So there's 3 causes of hyperthyroidism. There's autoimmune mediated hyperthyroidism from Graves. There's nodular thyrotoxicosis from thyroid nodules, and then there's thyroiditis. In nodular thyrotoxicosis and Graves' disease, you have an increased synthesis of thyroid hormone. In thyroiditis, you don't have an increased synthesis of thyroid hormone. You have destruction of the thyroid cells from inflammation that are releasing thyroid hormones. There's no increased synthesis. So giving someone an antithyroidal if they have thyroiditis, which is an inflammation of the thyroid gland, is not going to do anything. The question, it's not always straightforward, but on this board exam question, they're telling you she doesn't have proptosis. She doesn't have a brewery. They're giving you signs that she does not have Graves' disease is the bottom line. Her ESR is a little bit high, which you don't see here because I forgot to put it in. And she had a sore throat 4 weeks ago. So that's, again, on the board question, that's a hint. So the answer here, when you don't know why someone's hyperthyroid, is you do a 24-hour radioactive iodine uptake and scan. So basically what you do is you give someone radioactive iodine and then you scan their neck. And so people that have increased synthesis of thyroid hormone from Graves' disease or nodules will have an increased uptake. So Graves' disease used to have a large increased uptake, diffuse increased uptake. In nodules, you just see focal uptake. And then in thyroiditis, you see a decreased uptake again, because we're not increasing synthesis. We're just the cells are just being destroyed. So this is a case of thyroiditis, and it's, precipitated by whatever viral infection she had. A lot of patients that get these do have this underlying autoimmunity and disposition to becoming hypothyroid, but not always. Patients with thyroiditis typically are hyperthyroid, then they typically go through a hypothyroid phase, and sometimes they go back to normal, and sometimes they remain hypothyroid. You treat them symptomatically with beta blockers and sometimes steroids if they have a lot of pain or significant hormone elevation. Okay, this is a 72-year-old male. He's in the ICU for septic shock. He has a history of type 2 diabetes. He takes metformin, lisinopril, and a statin. He's intubated on pressors. He's getting saline boluses for 3 days, and he's getting all the appropriate treatment, but he's still tachycardic and his blood pressure is low. So we do an ACTH stimulation test because they're worried about hypocortisolism, and we see that he has a basal serum cortisol 15, and then he stims to 16. So other remarkable labs are that his serum albumin is 2.3 and his serum glucose is 134. So this is like an endocrine board level question. So probably not something you're going to see on your exam, but good to do anyway. So I'll just answer it for you. So what's the next best step in management? And the answer is nothing. And while this patient did not stimulate, patients who have albumins less than 2.5, the cortisol between 12 to 18 is typically normal. So what happens when people are sick is the cortisol rises and remains elevated without a circadian rhythm for days to weeks until recovery occurs. So cortisol secreted in a diurnal fashion. It increases in the morning, comes down a little, increases in the afternoon, and then overnight the production of cortisol is basically low. In Cushing's, the first thing that goes is the circadian secretion of cortisol. That's why we check a late night salivary cortisol, because at night it stops coming down and it's still going to be high. So the cortisol production in critical illness is resistant to suppression from exogenous glucocorticoids like dexamethasone. The more gravely ill the patient, the greater the stimulus for cortisol production, and the less the cortisol rises with cosentropin. And again, this is not ABIM board level sort of stuff, but the point is when the serum albumin is low, The free cortisol is normal if the total cortisol is between 12 and 18 is good for you guys to know, especially when you're in the MICU and might be important on your boards. So again, most patients are hypoproteinemic. This is why interpreting cortisol levels in the hospital is so hard, because people are sick and the serum total cortisol can underestimate the concentration of the free cortisol. You can check a free cortisol, it just takes a while to come back. You can have DHEAS is an adrenal marker. It's a useful measure of adrenal function in combo with cortisol. However, in critical illness, it's also ACTH dependent. So in normal times, it's a good marker of adrenal function, but in critical illness, the DHEAS falls, so it can't be used to determine adrenal function. That's why when it was back there, we're not really using it. Okay. This is a 65-year-old male. He's on the ortho unit. He's status post. He's 5 days status post total hip replacement. He's got severe left flank pain for the last 12 hours. He gets an abdominal CT that shows bilateral adrenal enlargement. Since his surgery, he's had poor appetite. He has trouble keeping up with the PT program, but otherwise he has really no past medical history, just hypertension, and post-operatively he's on low molecular weight heparin. He's ANO ×3. He's uncomfortable. His blood pressure is normal. His heart rate's a little high. He has a low-grade fever. He's obese but not Cushingoid, and there's no skin hyperpigmentation. His thyroid exam was normal. He's tachycardic. His abdomen is soft but tender on the left, where he's complaining of the pain. The rest of the exam is normal. This is his CAT scan. We're seeing bilateral adrenal enlargement here and here. What lab profile would you expect here? So the first point in this is interpreting what is going on. What do you guys think is going on here? So obviously something with his adrenal glands. So he's status post-surgery, and now he has pain, sudden pain. He has no past medical history of any adrenal problems. And now he has bilateral adrenal enlargement. What are we thinking about? And he's on a blood thinner. Okay, I'll tell you. Adrenal hemorrhage. In adrenal hemorrhage, is the adrenal insufficiency going to be primary or secondary? Is it going to be coming from the adrenal glands or from the pituitary gland? The adrenal gland. So we're looking for a profile of labs that's consistent with primary adrenal insufficiency. The sodium is high in this case, the potassium is low, the cortisol is high, the ACTH is high. This is ACTH dependent hypercortisolism. That's not what we're looking for. The sodium is low here, the potassium is high, the cortisol is low, the ACTH is high. So the adrenal glands are not making cortisol. This pituitary gland is appropriately responding. And because of the lack of cortisol, we see a low sodium and a high potassium. That's the right answer. I won't go through the rest because it's really, in this case, this might be something you see with secondary adrenal insufficiency. You have a low ACTH, a low cortisol, and a profile that's consistent with adrenal insufficiency. So adrenal hemorrhage is typically, it can be subtle, so that's why this is being brought out. This will also be on your boards. It's seen in patients typically with a history of thromboembolic disease or recurring surgery or recent surgery that needs prophylactic or therapeutic anticoagulation. Any coagulopathy can be causes. The symptoms are not often dramatic, so they can have pain of varying severity, lower back pain, chest pain. There's few clues on physical exam except for maybe a low-grade fever, and hypotension is we're at a bad stage when we get to being hypotensive. So, and often is mistaken for septic shock because the patient just underwent surgery. So it's always something to keep in the back of your mind. Again, we're going to see this is a primary adrenal insufficiency. So we're going to see subnormal cortisol and elevated ACTH. You expect hyponatremia and hyperkalemia. So cortisol has a negative feedback on vasopressin. So when you have a lack of cortisol, you have a lack of negative feedback on vasopressin. And that's why you have hyponatremia. And then you have a mineralocorticoid deficiency because the adrenal glands are being destroyed. And that's where the mineralocorticoid producing cells are, contributing to decreased potassium clearance. This is like endocrine board level sort of stuff, but it is interesting. So why are we getting adrenal hemorrhage? Because the adrenal gland each adrenal gland only has one vein. So any rise in venous pressure with or without thrombosis can make this vascular dam in the presence of coagulopathy that can lead to a hemorrhagic event. Stress with increases in adrenal blood flow contribute, and the muscular arrangement in the adrenal vein make it more susceptible to the formation of platelets. And also the adrenal glands have high epinephrine levels, obviously, which contribute to platelet aggregation. I think we're almost done here. Yeah, two more. I'll go fast. So this is a 31-year-old. She has Addison's disease. This will also something that you might see on your boards. She has a 3-day history of fever, cough, congestion, myalgias. At home, because she has Addison, she takes hydrocortisone 10 in the morning, 5 at night, and fludrocortisone. So again, when you have primary adrenal insufficiency, you also need mineralocorticoid replacement. Hydrocortisone does have mineralocorticoid properties. However, unlike dexamethasone or the other steroids, however, in order to saturate the mineralocorticoid receptors at a level that would be appropriate, you'd have to give too much hydrocortisone and it would make you iatrogenically Cushingoid. So at 10 and 5, we're not going to get enough mineralocorticoid replacement. However, so you need fludrocortisone. However, someone in the ICU and Addison's patients in the ICU on stress dose steroids, you don't have to also give fludrocortisone. That's an aside. She has a low-grade fever. She has no orthostatic changes. She has cervical lymphadenopathy. So basically she's sick. What are you doing next? And this is basically sick day rules for patients with adrenal insufficiency. We're going to increase the hydrocortisone dose. Patients who are under stress, they require more hydrocortisone. So you increase, especially when they have a fever, you increase by 2 to 3 times, depending on the severity of their illness. If they have a fever, usually by 3 times for a few days until they're better. What is this? Okay. 55-year-old comes in with a community-acquired pneumonia. Despite 5 days of appropriate treatment, he's still remaining febrile, tachycardic, mildly hypertensive. This is a good question because the past medical history is telling us he has hypertension and he has a history of OA treated with intra-articular injections of steroids. So he's showing signs of adrenal insufficiency. He has low-grade fever. He's hypotensive and he's not getting better from it with his pneumonia. He has a random cortisol of 9.5. The rest of the labs are relatively normal. And so what are we going to do here? Are we going to stim him or just give him steroids? We're going to give him steroids. And basically this guy has a secondary adrenal insufficiency induced by these injections. So any sort of steroid can cause adrenal insufficiency. It's always good to keep in the back of your mind. So I don't have any explanation here, but this random cortisol is 9.5 is inappropriate for the level of stress he's in. This cortisol should be much higher. So, you know, he's not mounting a response and that's why, and it's because he has suppression from the steroids he gets, exogenous steroids he gets. And this is the last one. I'll do this very quickly. This is a patient who's coming in with very mild symptoms. He's got abdominal pain and he doesn't have any hyperadrenergic symptoms. And he's coming in with this finding of this adrenal mass here. So this is a bigger adrenal mass that's round. It's confined to the right adrenal. And these are his labs. So his cortisol is okay. His ACTH is okay. His renin and ALT are okay, but his norepinephrines are high. His metanephrines are normal, but his metanephrines are high. And so the most likely diagnosis is a pheochromocytoma. And so basically this is the last slide. Pheos are chromaffin cell tumors that originate in the adrenal medulla that secrete catecholamine. So norepi, epi, and less commonly dopamine. So metanephrines are metabolites of the catecholamine. So norepinephrine is a metabolite of norepi and metanephrine is a metabolite of epi. And these catecholamines induce adrenergic symptoms. However, some of them do not secrete high concentrations of these catecholamines. And even when they do, not everyone has classic symptoms. So these pheo patients that actually physically come in don't always have these classic symptoms. They typically induce symptoms when the levels are much higher than the upper limit of normal. And usually levels that are less than 2 times the upper limit of normal are due to enhanced sympathetic tone or like medicines that they're taking, norepinephrine reuptake inhibitors. So they're usually false positives. When they do cause symptoms, they're usually greater than 2 centimeters and they have a high Hounsfield unit like we talked about before. So just something to keep in the back of your mind. I don't think that a case that's so subtle would be on your boards, but the points they're trying to make are the norepinephrine levels are like 7 times the upper limit of normal. So that's not a false positive. And they don't always have symptoms. So he's not complaining of these adrenergic symptoms, but that doesn't mean anything. Patients who have pheochromocytomas, they don't flush, they get pale. So because of the vasoconstriction. So people often will say, oh, they don't have the triad of headache and flushing and hypertension. It's not flushing, it's pallor. But again, just noting that this is real and this is real. That's what the point of the question is. That's all I got.
Thank you so much, Dr. Brown. I know that was a lot of information, guys. But the point is, like, you know, you get to see a lot of diabetes and like in primary care, but like adrenal and thyroid, it's something which you might see or you might not see, but it's heavily tested on both. So, you know, this might just be an introductory section for you. At least you know what topics to study. I'll just do 2 quick take-home points, and who will be our volunteer too. Okay, maybe something from thyroid that you guys kind of, think you'd learn new from this lesson. I mean, the lecture, sorry.
For one of the cases, like if a patient has a thyroid nodule, but the thyroid hormones are normal, you would want to do a fine needle aspiration instead of going for like an iodine uptake test.
Yeah, and there's a very beautiful algorithm in MixApp for thyroid nodules. If you just master that, it's like 3 simple steps. You'll not get any question wrong. So very good.
Increasing the levothyroxine dose by 30% in pregnant patients in the first trimester of pregnancy is my take-home point.
Does anyone remember any specific criteria or anything to look for adrenal masses? When do you get concerned? When do you not care? Okay, so size of 4 centimeters. Anything else on radiology? Any specific units? Okay, perfect. All right. You guys did great. Thank you.
Something really quick. I know you want to leave, but as Arpan was saying, this is rare, right? You won't see it in your daily practice. Even Dr. Brown was saying that she was only able to see 1 myxedema coma. And this is very comprehensive. As you saw in many of the questions, you need to take the clinical picture, take the level of hormones compared to the actual clinical status of the patient, and images and things. So the best approach really is to have a systematic strategy and always try to come up with your own algorithms based on the ones you have available with MixApp, with UWorld, but this is something you will definitely be tested on. All right, thank you.